Hey, this is Dr. Ben Weitz, host of the Rational Wellness Podcast. I talk to the leading health and nutrition experts and researchers in the field to bring you the latest in cutting-edge health information. Subscribe to the Rational Wellness Podcast for weekly updates. And to learn more, check out my website, drweitz.com. Thanks for joining me, and let's jump into the podcast. Hello, Rational Wellness Podcasters. Thank you for joining me again today. Our topic is atrial fibrillation with Dr. Aseem Desai. This is actually the most common form of arrhythmia diagnosed in clinical practice. It's estimated that between 2.7 and 6.1 million Americans are living with afib. I got that from Dr. Desai's book. Interestingly, there's such a broad range. I guess it's not clear necessarily whether people know they have this or not, but that'll definitely be something we want to understand. But as our population ages, afib incidence is increasing. So I just mentioned arrhythmia. So what is arrhythmia? Well, this is basically a problem with the rhythm of the heart, which occurs when your heart beats too fast, too slow, or irregularly. Some forms of arrhythmia are harmless, while others can cause serious damage and even death. Your heart has 4 chambers. There are 2 upper chambers known as the atria and 2 lower chambers known as ventricles. Your heart also has a built-in electrical system that controls the coordinated contraction of the muscles of these chambers, resulting in your heart beating between 60 and 100 beats per minute while at rest. If the heart beats too fast, this is a type of arrhythmia known as tachycardia, while a slow heart rate is known as bradycardia. Atrial fibrillation is a type of tachycardia that originates in the atria, and it can be a serious condition that can lead to stroke if it's not controlled or managed properly. Now, we've had a number of discussions about the cardiovascular system on this podcast, but we essentially have focused on conditions like how to prevent and reverse atherosclerosis and hypertension. So essentially, we focused on to use an analogy from construction, we've focused on the plumbing and then the engine that helps drive the blood through the body, which is the heart. But now we're going to talk about the electrical system of the heart. Our interview today is with Dr. Aseem Desai, who's a cardiac electrophysiologist, which means that he's a physician specializing in heart rhythm disorders. And he's been caring for people with atrial fibrillation for over 17 years and currently practices in Orange County, California. He's published a number of scientific papers, and he just published his first book, Restart Your Heart, the playbook for thriving with AFib. Dr. Desai, thank you for joining me today.
Thank you very much, Dr. White. Thank you for having me.
So, before we get into the specific questions about the cardiovascular system, I noticed that you and I have something in common, which is that we both have an undergraduate degree in philosophy. How did you come to study philosophy with an interest in cardiology?
I love it. I love that I'm meeting a fellow philosopher. We can talk about Aristotle the whole episode exactly. Here. Yeah, no. So I was part of the 7-year medical program at Northwestern. So as a high school senior, you gained admission to college and med school at the same time. And the idea was to foster an interest in liberal arts. And so we did have a double course load, pre-med as well as a liberal arts major. But it really kind of opened my mind. I think I tend to look for challenges, and I don't know about you, Ben, but this was like probably one of the biggest challenges was reading philosophy and writing the papers. And what's interesting is to this day, I still use a lot of the logical reasoning, the deductive reasoning, even when I'm doing, when I'm taking care of heart patients and making diagnoses.
Right. I know for myself, one of the things that I got out of philosophy is when you study philosophy, you learn that there's not a lot of concrete answers, but you want to get closer to those answers. And the way you do that is by being critical and asking good questions. And so I think that's also important in medicine, to be critical when people make statements and challenge them, and try to get closer to the best answer we'll have at that point in time. So I think that's how philosophy has helped me.
Absolutely, Ben. And to your point, I also think it keeps you with an open mind, a beginner's mind. You know, I think that as physicians, we do have a tendency to not have that, and especially subspecialists.
Think we know everything, yeah.
Yeah, right, exactly. And so I think that, I look forward to learning as much from you as you will from me, perhaps during the podcast, and as well as your viewers. I always welcome feedback, your listeners. So I do think that these two philosophers on this podcast today will have a lot to say to each other.
So how do you come to specialize in heart rhythm disorders?
Well, it's very personal. So when I was about 3, my dad had a heart attack. He was 37 at the time. And although I don't have much memory of that, I think, many things for kids, they get ingrained in your brain, even if you may not be able to process what's going on. And he was an oncologist. So I actually saw him not only as a physician, but I saw him becoming a patient. And I saw how this heart disease really robbed him of enjoying his life. He was fearful that he was going to have another heart attack. And so as I went through college, high school and then college, I had an interest in science. And unfortunately, in the medical school, my second year of medical school, he actually suffered a cardiac arrest. And he was in India at the time. And in most cases, the cardiac arrest is actually due to abnormal rhythms from the ventricle, from the bottom chambers, called ventricular tachycardia and ventricular fibrillation. And in many cases, as you mentioned, with regards to the plumbing of the heart, a heart attack or a blocked artery, the clot that forms in a plaque, can actually induce a ventricular tachycardia and ventricular fibrillation and cause sudden death. So I think that really got me focused on the electrical system of the heart. And as I went through training and residency and then in fellowship, I just found the electrical system quite a challenge. To be honest, I was terrified of cardiac arrhythmias when I was a medical resident. They were really hard to understand and interpret. Electrocardiograms, which are the recordings that we do for the heart's electrical system. And I don't know about you, Ben, but mentors kind of come across your paths in different ways. And I was a medical intern at Stanford, and I was sitting reading EKGs as part of the cardiology rotation. And it happened to be right near the electrophysiology office. And electrophysiology is the branch of cardiology where we do study and treat these rhythms. And one of the attending physicians saw me reading EKGs and came up to me and said, "Hey, you want to write a paper with me on IV amiodarone, which is a drug that we use for cardiac arrhythmias?" And the next thing I knew, I was writing a paper, had no idea what I was doing, but I did publish it. And I think the story goes on from there.
Yeah, I had sort of a recent experience with arrhythmia. I had an EKG done, and after the EKG was done, my doctor left the room, came back and repeated it, and then decided to leave the room and repeat it again, and he brought another doctor in. So in between, I got up and looked at the sheet of paper that read out, and the paper read that this patient is having an acute MI. And I was feeling completely fine. And he came back in the room and I said, "Hey, doc, whatever's going on, I could have something wrong with my heart, but I am not having an acute MI. And so it turns out I have an early repolarization variant, and which is something that happens in people who are athletic. And so then I also had to have hernia surgery recently, and I had to make sure everybody was on board with this, that they suddenly weren't going to freak out when I was under anesthesia and or anywhere along the line that somebody saw my EKG.
Well, I think you make a great point, Ben, that You actually should carry a photocopy of an EKG. If you have an abnormal EKG and it's truly normal, it's just a variant of normal, which is what early repolarization is, it's always a good idea to actually carry a copy of it.
I do. I have it in my phone.
Yeah. Because like a radiologist with chest x-rays, as cardiologists, we often will look at an old EKG to really get a sense of, is there a new change? And it really illustrates the room that we have to move on our artificial intelligence algorithms in these EKG machines.
Certainly the readout from that machine was not correct. Maybe you could explain a little more about exactly what is arrhythmia.
So arrhythmia is a generic term used to describe any abnormality of the heart's electrical system, and that can result in something called bradycardia, where the heart rate goes too low and often presents with fainting or extreme fatigue. It can result in tachycardia, which is where the heart rate goes too fast. A common symptom there would be a sense of a racing heartbeat. And sometimes if the heart rate goes fast enough, and in many cases it can go over 180, 200 beats a minute, people can faint with that as well. And then you have irregular heartbeats. And so irregular heartbeats are really broken down into two categories: benign, which include what we call premature beats that can occur from either the top chambers, the atria, or the bottom chambers, the ventricle, or conditions such as atrial fibrillation, which are quite dangerous and can cause stroke, congestive heart failure, as well as reduced quality of life. So it really is a generic term, arrhythmia, and it encompasses bradycardia, tachycardia, and irregular heartbeats, afib being the most common. But it's important to mention that not every irregular heartbeat is afib.
How dangerous is afib?
It's actually very dangerous. It depends on your stroke risk factor score, first off. So we use a scoring system called CHADS-VASC. It's an acronym. And you calculate the number of points. It includes things such as congestive heart failure, high blood pressure, age, diabetes. And as you add up these points, there's a lot of large databases that have shown that once you hit a score of 2 or higher, your stroke risk is actually quite high with AFib, and it continues to go up as the points get added up. And so we, just like many areas of medicine, I'm sure in your case as well, you look at a person's health and you do a risk stratification, priority stratification, and it's no different with AFib. So you can have young patients actually that get AFib, especially athletes. We're seeing a larger population. Those patients tend not to be as high risk for stroke. It certainly impacts their quality of life, though. NFL players have a 6 times higher risk of AFib compared to their counterparts.
Really?
People don't realize that.
Why do you think that is?
That's a great question. So we've now learned that the nervous system is a big component of heart rhythm problems. So the nervous system, just like inflammation is a big part of many different illnesses, including coronary disease and GI issues, the nervous system, the autonomic nervous system, which includes the fight or flight, which is the sympathetic, and the rest and relax, the parasympathetic, actually is heavily involved in the genesis of cardiac arrhythmias. So, for example, athletes have often a low resting heart rate, and that has to do with the vagus nerve being that part of the nervous system that helps to preserve your energy, really. There's no point in your heart rate being 90 beats a minute when you're sleeping. So a good conditioned athlete often has a low resting heart rate. But just like anything in life, extremes may not be a good thing. And people who have a very low resting heart rate have an easier ability to have what are called these premature beats that I referenced earlier. While I said that premature beats are benign, that's not exactly true. If you have enough premature beats, especially from the atria, and under the right perfect storm, so to speak, it can be a trigger for atrial fibrillation. So one thought with the football players and other athletes, including triathletes, for example, is that this low resting heart rate predisposes to these premature beats because there's a longer time interval between beats with a low resting heart rate. So it's easier for these extra beats to be a trigger. And if you think of AFib as a fire, you have the matches and you have the wood. And the matches would include things such as these premature beats, would include things such as alcohol, a variety of other factors. And then the wood are the risk factors for AFib, which would include things as age over 65, diabetes, sleep apnea, a whole host of things that we can get into.
So would it make sense for an athlete who has a lower resting heart rate? For example, myself, actually, when I was in the pre-op, my heart rate was right around 50 and dipped to 48 and up to 55. And they kept going, "Oh, you're an athlete. You're an athlete." And they were freaking out a little bit. Does it make sense for somebody with a low resting heart rate to try to raise their resting heart rate?
Well, it's a good question. And the problem is you can't really do that from the standpoint of, other than taking in stimulants. So just
could you, for example, take in more sodium? Could you eat licorice? We just heard about somebody who ate so much licorice that they died, actually.
Right. Yeah. The problem with licorice consumption is it more predisposes to dangerous heart rhythms rather than purely increasing your heart rate. And it's not the low heart rate in and of itself. It's with arrhythmias like AFib, it's the perfect storm. So we're now learning there's quite a bit of complex genetics with AFib. So not every athlete with a heart rate of 40 or 50 is going to get AFib by all means. But if that athlete consumes a lot of alcohol, if that athlete has unrecognized sleep apnea, if that athlete puts on weight after they retire and goes on to develop high blood pressure or diabetes, that's really, it's that adding up of risk factors. It's just that when you have a low resting heart rate, that kind of puts you at a little bit of a higher risk. But we're still working it out. We're still trying to determine what's going on. But you ask a good question, which is it the heart rate itself? And I would say no, it's that overactivation of the parasympathetic nervous system. And it's not just the heart rate, the actual vagus nerve, when you stimulate it, either in laboratory models, or even when we're doing a procedure called catheter ablation and you stimulate the vagus nerve, which you can do, it'll actually trigger AFib, and it has nothing to do with the low heart rate. It's literally stimulating that nerve and the release of acetylcholine and other components that can be a trigger for arrhythmias.
Now, is it the overstimulation of the parasympathetic or the sympathetic?
That's a great question. So now we believe in most cases it's actually the parasympathetic that's the problem.
Well, that's interesting because, when we have patients who have anxiety or they have adrenal problems or they have fatigue, we're always working with them to increase parasympathetic stimulation, because the thought is everybody's stressed, everybody's in sympathetic mode all day long, and that's why they're drinking caffeine, because they want to be in the sympathetic mode because they're not sleeping enough and they're trying to get more work done, etc.
Well, you're absolutely right. For emotional and mental stress and even physical stress, the parasympathetic nervous system is a very important part. You I'm sure, are aware of heart rate variability, and using heart rate variability in certain breathing techniques activates your parasympathetic nervous system. So it's not so much, as you mentioned, about calming down your fight or flight. It's about enhancing your rest and relax. It's about enhancing your parasympathetic nervous system. The only reason why I'm commenting on this from the standpoint of arrhythmias is that the parasympathetic has been implicated. Honestly, both parts of the nervous system have been. So we clearly see sympathetic triggers. If someone's under a lot of stress and their heart rate goes up, they can end up having more premature beats. So it's not, I would just say anything out of balance in the body, right, is not a good thing. And so when you come to AFib, we love using this term, the perfect storm. You have a few risk factors, you have a few of these matches, you have a little bit of that wood, and then it creates the fire. And that's why on a given day, there's something or a combination of things that can lead to a patient's first AFib episode.
Well, it's interesting when we're talking about these risk factors, because it seems like this comes up all the time. At this point, we're still going through this COVID-19 pandemic, and what comes up all the time is that people are likely to have a worse prognosis if they have any of these chronic diseases, like being overweight, having hypertension, having diabetes, having sleep apnea, having lung disease. These are the same chronic conditions that are so prevalent in our society that make it more likely that you're going to have AFib.
That's absolutely right. And if you look at obesity, for example, that is one of the number one risk factors for AFib. And there's a lot of different mechanisms that are thought of with regards to that. But obesity itself leads to many of the other conditions you mentioned, the diabetes, the high blood pressure. Chronic high blood pressure increases the stretch in the left atrium, which is the top left chamber of the heart. That's the trigger for AFib. There's so many different types of mechanisms. But as you mentioned, with COVID, this inflammatory component is critical, right? I mean, that's why people get this multi-organ system failure. That's why people get this myocarditis that you're seeing in cardiac cases. And so many cases, or many people believe, I should say, that AFib is along the same lines. It's an inflammatory disease. So you do see elevated biomarkers in the setting of AFib. We just don't know what to do with those biomarkers, but we do know that there's an inflammatory component like many things. I think that's also why probably treating your body with food as medicine, that certain foods definitely and supplements definitely do help cardiac arrhythmias. But I think what distinguishes it a little bit, AFib, from some of these other things we're talking about, is this interplay with the nervous system. So I think the gut, as you know, the enteric nervous system in the gut, there's that secondary nervous system. The heart has its own nervous system. And so it's interesting to see this sort of two-way street between the brain and the heart and the brain and the gut. And I think when those things are out of balance, and it's usually nature and nurture, there's some genetics probably, and then there's environmental triggers. So many things we're not aware of, right? There may be multiple toxins in the environment that are big components of causing AFib as to why one person gets it and one person doesn't. So there are well-defined risk factors: age over 65, diabetes, high blood pressure, thyroid disease, heavy alcohol use, sleep apnea, obesity is the big one. And then there's ones that we really haven't determined yet. But I would say that you see this, I call it the electrical epidemic, AFib. It's an epidemic because as we get older, we're living longer. And so it's arthritis of the electrical system. So when you get AFib, when you get older, you could be a totally healthy person, lived a totally healthy life, and still get AFib. And it has to do with scar tissue that builds up in your electrical system, just like it would in your knee. So that's the age-related factor of AFib. And then you have that obesity component that our society, as you mentioned, Ben, I mean, we're getting unhealthier and unhealthier. And the obesity epidemic is probably a big reason why we're seeing AFib. We're seeing a lot of AFib in our practice right now. So our patients who have AFib are getting more AFib right now during COVID. Two reasons, we think. One is increased alcohol consumption. One glass of alcohol associated with an 8% risk of an AFib episode. It's not a small thing. And then the lack of physical activity and weight gain.
Yeah, and the stress as well.
The stress is huge. Absolutely. We see, it's interesting you mentioned the stress. Just in observation, there's a lot of people who they'll be in AFib, they'll go into this AFib episode at home. Their heart's racing, it's going irregular, they're feeling terrible because the heart's an engine. So when you go into AFib, you lose about 30% of the pump efficiency of your heart. It's almost like losing a few pistons in your engine. That's what the atria do for you. And when you go into AFib, the part of the heart muscle beats very poorly, very chaotically. So people are feeling terrible and they go into the hospital, and they've been sitting in AFib even sometimes for a few days, and they go into the hospital and the doctor's getting ready to shock the heart back into rhythm, called the cardioversion, which is often something that's done for AFib. And literally you're getting ready to press the button and the person converts to a normal rhythm. And the hypothesis here is that people feel safe when they get into a hospital in this context. Not always, but in this context, they feel safe. And so we see it over and over again where people, that's why I'm a big believer in mindfulness. I do a daily mindfulness practice. I have a lot of interest in that. And we definitely see through activation of the parasympathetic and calming down that fight or flight response. I mean, I mentioned all these things about parasympathetic and arrhythmias, but don't get me wrong. It's not that the parasympathetic is bad and it causes arrhythmias. It's just that we're learning specifically in athletes. But what's also interesting is GI triggers for AFib. So people who have acid reflux, the esophagus sits right behind the heart, or people who eat like a really large fatty meal activates the vagus nerve. So again, it's overactivation.
Yeah, I mean, be honest with you, in my practice, we see a lot of patients with GI disorders, especially irritable bowel syndrome and reflux, these functional disorders, and they're extremely common. When you combine those with obesity, and 70% of the patients in this country are overweight, you add in the rates of diabetes and hypertension and some of these other conditions, it's surprising that we don't have more people with AFib.
Oh, absolutely. And, I mean, I've been on, different kinds of shows and I've talked about these things. And one of the things I started realizing and gotten humbled about, is patients are saying to me, they're like, this is great. You're telling me all these bad things. Like, how do I change my life? And I don't know if you've heard of Thrive Global. It's an organization founded by Arianna Huffington.
Oh, I know who she is, but I haven't heard of that organization.
So Arianna and I had a chance to connect as I wrote this book. Partly because of my interest in mindfulness, and I reached out to her to get her thoughts on the book, and she invited me to be a contributor for this website. So for your listeners out there, I would definitely encourage you to check out this website, thriveglobal.com, because they're addressing so many issues of COVID right now. Parents who are working from home, schooling people at home. I mean, everything really under the sun. But what I like, their theme is micro steps. So to make a behavior change, it's a micro step. It's not what we used to think, which is like, 21-day challenge, give up this. It's really making those small changes every day and then and building on that and having that accountability. So I just wanted to mention that, because you and I are having this great discussion about all these risk factors, but I don't want people to be demoralized into thinking that there are ways to change. And I know that you do that on a regular basis with your patients.
Absolutely. And, the greatest thing that could come out of this COVID crisis is if there's more awareness about doing something about these chronic diseases that result from poor diet and lifestyle, like we've just been talking about, like obesity and hypertension and diabetes and et cetera, et cetera. America needs to wake up and get healthy and exercise and eat healthy and, get control of their stress and all these conditions like AFib we're going to see less of.
Yeah, I totally agree. I mean, it's interesting how a virus that is decimating part of humanity is also connecting part of humanity and waking up part of humanity, that all of these things we're talking about, these are huge risk factors for massive COVID infection and poor outcomes.
Yeah.
So I think you're right. Like, people are sort of saying, well, this is this end goal that we all have of not wanting to get infected and certainly not wanting to have a bad infection.
I've really been enjoying this discussion, but now I'd like to pause to tell you about the sponsor for this episode of the Rational Wellness Podcast. This episode is sponsored by Pure Encapsulations, which is one of the few lines of professional nutritional supplements that I use in my office. Pure Encapsulations manufactures a complete line of hypoallergenic, research-based dietary supplements. Pure products are meticulously formulated using pure, scientifically tested and validated ingredients. They are free from magnesium stearate, gluten, GMOs, hydrogenated fats, artificial colors, sweeteners, and preservatives. Among other things, one of the great things about Pure Encapsulations is not just the quality products, but the fact that they often provide a range of different dosages and sizes, which makes it easy to find the right product for the right patient, especially since we do a lot of testing and we figure out exactly what the patients need. So, for example, with DHEA, they offer 5, 10, and 25 milligram dosages in both 60 and 180 capsules per bottle size, which is extremely convenient. And now, back to our discussion. Are there certain diets that are associated with less risk of AFib or that can be beneficial for patients who have AFib?
Yeah, I think that,
and keep in mind the background is that, there's a lot of confusion today as far as what the best diet is. And it's almost like partisan politics. We got the vegans on one side and the people who only eat meat, the carnivores on the other side. And then we've got the paleo and the Mediterranean, and everybody's claiming that their diet is the best.
Yeah, and I think it raises the point, this is for AFib, this is for diet. You have to individualize to your case. You may have a certain blood type, if you believe that, where a certain diet is better, or you may have a lot of chronic inflammatory disorders, whether it's fibromyalgia or lupus or even cancer, and a vegan diet, with all the data we know about reducing inflammation on that. So As cardiologists, we typically recommend the Mediterranean diet. There's a fair amount of data with regards to that, lean proteins, good fats. But I think that it really comes down to balance. But you also have to look at your individual situation, because whatever food plan you adopt, you want to adopt something that you can stay with the long term. You can have your cheat day once a week or what have you, but you want something that's really going to sustain you long term, which is why I'm not a big fan of things like Atkins and really high fat diets. I agree, sugar is not good. But I think you really have to individualize, and AFib is the exact same way. No two patients with AFib are treated the same or are the same. So some people, they may be able to take care of their AFib purely with diet and lifestyle modification, losing weight, not drinking alcohol, et cetera, treating sleep apnea, which is very underrecognized as a trigger for AFib. Some people, they need a medication in some cases. Some people need a catheter ablation procedure, and there's other kinds of things that we can do. But AFib is a progressive disease. AFib begets AFib. This is an electrical cancer. People need to know about this disease. They need to know how to screen themselves for it. They need to know how to help their loved ones with it, because you don't want to wait until someone has a stroke to figure out that they have AFib. And nowadays, with all these great biometric tools, Apple has their EKG function on several of their watches. KardioMobile is a device you can buy for $90 on Amazon. These are devices that actually allow you to record an EKG and tell you with a reasonable amount of accuracy, not perfect, that you may be having AFib. So we are big proponents now of early detection, early intervention. So if someone gets diagnosed with AFib, for example, you don't want to just say, lifestyle and diet, and let's regroup in 4 weeks. Every episode of AFib, even if it's 5 minutes, and this is really important, changes the cellular and electrical architecture of the heart to want to have more AFib. It's a muscle memory thing. So we've had cases of patients where they think they're only having 1 or 2 episodes a year, where in fact they were having a lot more silent episodes. That's common, actually, while people are sleeping. Silent episodes of AFib, they don't feel anything. And their AFib is progressed by the time they get a treatment. So, early detection, learn how to take your pulse after you brush your teeth. It should be like a metronome. It shouldn't be fast and irregular. Many patients have very subtle symptoms. This is really common.
Yeah, what are the symptoms of AFib?
Yeah, I'm glad you asked. So it depends on your age. So younger people, and we've seen people as young as 18, by the way, tend to get that rapid, irregular heart rate, the palpitations that we described. But it's more than just skipping beats. It's a tremendous amount of fatigue or shortness of breath. Because again, the engine analogy, you lose pistons when you go into AFib. That's different. Like if you're having these skipping beats, these premature beats, you don't lose pistons in your engine. They may be bothersome, but you don't feel terrible. And with AFib, that's the big thing, is this general sense of lack of energy, fatigue, shortness of breath. But what's interesting is as people get older, and especially people who aren't that healthy, who aren't that active, they may not be aware at all they're in AFib. They'll show up for gallbladder surgery as a pre-op, and they're in AFib. We see that so commonly. And then you ask them, well, over the last 6 months or year, have you noticed a change in your endurance or activity level? Yeah, I have. I just thought I was getting older. We hear that so commonly. Well, it's not until you restore someone's rhythm back to normal, which is what we often do in those cases, at least once, at least as a trial. When someone says they don't have symptoms with their AFib, we believe as electrophysiologists that unless there's a strong reason not to, everyone, or most people, I should say, not everyone, most people should at least have some kind of attempt at restoring the rhythm, because you don't know how much you're actually having symptoms of something until you restore the rhythm. It's like having a bad knee and doing less. You don't really then decide to have a knee replacement and realize that you could do more. So it's the same thing with AFib. It's the great masquerader. It's electrical cancer. There's so many different presentations. And that's why the early detection, these devices that I mentioned, are so important.
So the most common symptoms, list like 4 or 5 of the most common symptoms.
Yeah. So most common symptoms: fast, irregular heartbeat called palpitations, shortness of breath, sometimes chest discomfort, tremendous fatigue. And that would probably be, and then unfortunately, stroke is an often common presentation of AFib where there's no symptoms. But I would probably say the fatigue part. And what the key thing with any of these arrhythmias in the beginning, they're episodic. So what's different with the heart, like the coronary arteries, the 3 coronary arteries, it's plumbing, as you mentioned. So if you have a blockage, it's going to show up on a stress test. It's going to show up on a variety of testing. AFib, it can come and go. It's like the electrical system in your car or your house. It'll act up sometimes, and then it won't be there. So you show up to a doctor's office for an EKG, and then you come back in 6 months, and you're still in normal rhythm. You could be having AFib that night, and you don't know it. And it's not until you go from this in and out AFib, which is called paroxysmal, to continuous AFib, which is called persistent, that people really then get diagnosed. And the problem is, by the time you get to persistent, the treatments are much less effective. We have lots of ways of treating people with persistent AFib. That's an important point. One of the reasons I wrote this book is there's so much misinformation out there. People are told they have to live in AFib. It's too far gone. There's nothing that can be done. And in the introduction of the book, I talk about a man who was told that for 5 years, continuous AFib, and we got him into rhythm because of current technology, as well as the lifestyle changes. So those would probably be the most common symptoms. I wanted to circle back to your question, which I didn't really answer about diet. Magnesium is really important with regards to, and I think the important thing about magnesium is you can't go based on a blood level. 90% of magnesium is stored in your tissues, not in your bloodstream.
Right. And
that's the same with potassium, as you know. So we have a low threshold to recommend a magnesium supplement to someone with heart rhythm issues, unless they have advanced kidney failure. That's really the only time where you want to be careful about the magnesium. As far as like a specific diet, I wouldn't say, I'd be curious to see if you've come across anything in your research. I haven't come across anything that says, this diet is really good for AFib, but I would definitely argue that anything that results in reduced inflammation in your body is likely going to be a good thing for AFib. If nothing else, it's going to help your risk factors, right? It's going to reduce your obesity and all these other things, which then help your AFib. So it's really about trying to prevent the AFib. That's where the diet can be important.
There are now a number of forms of magnesium that we use frequently in our office. And so there's magnesium citrate, magnesium glycinate is known to be better absorbed and have less issues with bowel laxity. We'll use magnesium citrate if somebody is constipated. We'll use magnesium threonate, which has been known to affect the brain and central nervous system a little better. Is there a form of magnesium that you think is more effective for AFib?
I'm so glad you asked that, because a lot of people will just go to Costco or what have you and pick up whatever magnesium's on the shelf. And this is nothing against Costco, by the way. It's more magnesium oxide.
I'm with you.
Yeah, magnesium oxide is one of the worst
I got this big giant bottle of fish oil for $5.
Exactly. Well, there's a reason why it's $5. So, but magnesium oxide is probably one of the worst absorbed forms of magnesium, and it's one of the most common sold ones in stores. So, the ones you mentioned are great. Magnesium citrate, it actually comes. I love Natural Calm. Natural Calm is a product that you find online, you find in stores.
It's a powdered form of magnesium.
It's powdered. It actually comes as a gummy. Now the gummy has some sugar in it, so you got to be careful about that one. Forget the gummies. So, but magnesium citrate is a good one. Magnesium glycinate, as you mentioned, Doctor's Best is a really good brand for magnesium glycinate. For example, magnesium malate. Malate is a really good one. And taurate, magnesium taurate. So taurate has kind of more of a specific cardiovascular effect. It's sort of derivative or related to taurine amino acid. And there is data with regards to taurine and heart health and even rhythm. So there's a company, Cardiovascular Research Lab, makes a magnesium taurate that's, we will often prescribe to people. So it's really about just getting people to take it. And I always tell people, go based on the serving size of the bottle. People always ask what dose you should take. It's very manufacturer specific, company specific. But I would say those would be the main ones to consider.
Yeah, I would like to say when it comes to magnesium, manufacturers are often very careful and often will recommend, one tablet or something like that, but they have no idea your particular circumstances.
Right.
And, for the most part, the only side effect of taking more magnesium is that you'll get diarrhea, and you'll know that pretty quickly. So you very well may need 400, 600, even 1,000 milligrams would not be at all excessive for our magnesium needs. So, a lot of times just, what it says on a bottle may not be what you need.
I'm glad you raised that point, Ben. A few things. One is, we've seen cases where, like, if we give someone magnesium glycinate, hey, go based on the surgeon sounds on the bottle, continue to have rhythm issues, whatever the rhythm issue is. And then we add in another magnesium. So the combination of magnesiums, I've had one patient who said, well, the glycinate didn't work, but when I added in the taurate and lowered the glycinate, so you really have to titrate based on, if you're taking it for palpitations, for example, or AFib, you want to titrate it based on your episodes. Is your heart calming down? That's the point of the magnesium, is if there's what's called phase 2 of the action potential in the heart, in the electrical system. It's part of your heartbeat. And magnesium and calcium have this exchange pump in the heart cell. And that's the theory behind why magnesium helps so much as a stabilizer of the electrical system. And the point you made about the GI distress. So we do have a fair number of patients that just can't tolerate any form of magnesium orally. So you have magnesium oil, you have bath flakes. There are other ways of taking magnesium that you can absorb some.
And the glycinate has less effect on the bowel. But taurine is another supplement just used individually. Have you had experience with using that?
Yeah, I have one gentleman actually who, of course, I'm telling you stories about different people. We don't have these large randomized trials, but I have one gentleman who he struggled with premature atrial beat. So these are benign things, but it just debilitated him because if you've ever had one, it feels like your heart's like going through this roller coaster. And so he tried initially the natural calm. That didn't really work for him. He switched to the glycinate. That didn't really work for him. So then we had him on magnesium malate, and then we added a little bit of taurine in, and that not the full dose of taurine that's often recommended. And that really calmed him down. So I do think that there's a role certainly for taurine. My go-to, if someone's having rhythm issues or heart issues, is to say, start with magnesium, start with glycinate, as you mentioned, is well absorbed. If it doesn't work, maybe consider magnesium taurate or natural calm. And then if you continue to have issues, that's where you start to think about these other things. And it's also important to mention, just for your listeners, there are a lot of drugs that deplete your body of magnesium. And you have to be aware of that. Proton pump inhibitors, for example, that block acid secretion for ulcer disease, those deplete the body of magnesium. The diuretics classically deplete your body of magnesium and potassium. So to your point, Ben, those are people who probably need to have a supradose of magnesium because they're losing so much of it. And the last point about magnesium I'll make is intravenous magnesium has a powerful antiarrhythmic effect. And what that means is we have people who come into the hospital with AFib or with what's called ventricular tachycardia, dangerous heart rhythm, and you just give them magnesium even with a normal level, and it has this amazing immediate calming effect. And I mentioned with the magnesium that the serum level is not very helpful. You can ask your doctor to order what's called the RBC magnesium level within the blood cell, and that tends to be a little bit more accurate.
Yeah, we use that regularly. A few other supplements. Have you had any experience with coenzyme Q10, which is frequently recommended for heart health?
Yeah, I obviously recommend it to my patients generally for heart disease.
By the way, CoQ10, since we're talking about nutrients that are often depleted, cholesterol-lowering drugs like statins deplete the body of CoQ10.
Yeah, it's so interesting how we have people in so many treatments that fight each other. It's just like they're in the ring together and they're fighting each other, and it's sort of like you're not really sure what net outcome you're having.
Oh, yeah. Statins increase your risk of diabetes, and some of the most common diabetes drugs increase your risk of heart disease.
Right, exactly. So I'll be honest with you, I don't have a lot of experience or knowledge of specifically coenzyme Q10 and its impact on the heart's electrical system or AFib. Have you come across anything in that regard? With
I've seen some studies on it, and CoQ10 seems to have a lot of benefits for congestive heart failure, for a series of issues with the heart. So it's probably one worth experimenting with. And another one is hawthorn berry, which is often included in supplements for hypertension and heart health.
Yeah, my feeling on supplements is, as you know, there's a lot of criticism from Western medicine on these. I think having functional medicine is such an amazing step forward, that you have physicians and practitioners from all different disciplines, really focused on maintaining function, not so much on giving a pill or doing a procedure. But I think that people just need to be careful that that the supplement alone isn't going to necessarily fix the problem. And there is definitely a role. I mean, we do a lot of catheter ablation. So I'm a very integrative electrophysiologist, but I'll be honest, catheter ablation, if you look at all the different treatment options for AFib, I'm talking about people now who have the disease that is not being managed by just diet and lifestyle. It is a highly effective form of treatment, and there's a lot of misinformation, including from healthcare providers, about the efficacy of catheter ablation, that nowadays with early AFib, early onset AFib, paroxysmal, we have success rates of almost 85 to 90% with a risk of around 1%.
What do you hear healthcare providers saying that's incorrect about ablation? What's the common misconceptions?
Yep. It's too risky and it doesn't work. And then number two is it's not going to work for you, patient, because your AFib is too far gone. And then the third is, well, it doesn't make sense to treat your AFib or try to get you into rhythm because you're not having any symptoms. So those are the three. And this book that I wrote is not just for patients or family members. The book is for healthcare providers, not just for education, but it's hard to nowadays in a 20-minute patient visit, how are you going to talk about such a complex disease? And we just have these kind of 5-page pamphlets that really don't tell you much. So the idea is really to provide people with a little bit more detailed information. But, catheter ablation, for those of the listeners who haven't heard the term, it's simply a way of destroying abnormal tissue and preserving normal tissue. So destroying cells that aren't supposed to be there. So if you think of the sources of AFib, which are called the pulmonary veins, as like castles of AFib sending out sparks, or kind of the fire analogy that we use, we're essentially creating some insulation around the fire. We're creating insulation around a broken wire. In drug therapy, there's a role for it, but antiarrhythmic drugs, which is what we use, they have such a high side effect and toxicity rate. And at best, the most effective one, which is amiodarone, has only about a 40 to 50% long-term success rate. So again, our first step always with heart disease or any kind of disease, including AFib, is diet and lifestyle, lose weight. That can make a huge, I've had patients that have had ablations and they were overweight, and their AFib kept coming back. And then when they lost the weight, their AFib didn't come back. And that's something that, shame on us as electrophysiologists in our field, that we're now learning. You have to optimize those risk factors before and after any intervention to have the best outcome. And there is this mentality, unfortunately, in our society about, sort of quick fix, do an ablation. There's a lot of sort of altered expectations. People come in and think that the ablation is going to reduce the risk of stroke or fix their AFib. And it's a big picture, just as what you do. It's a big picture functional medicine, holistic standpoint. You got to manage everything. Everything's got to get in balance.
Yeah, I guess when I think about AFib, the idea of doing a procedure that could potentially cure it instead of having to take some of these drugs for the rest of your life that have all these side effects, to me, that sounds much more appealing. On the other hand, when I watched one of your videos describing how you do the ablation, boy, it is a really complicated procedure that involves threading this little wire into the vein, going through one side of the heart into the other side of the heart. And it makes me realize you really want an expert who's going to do that, because it is, at first blush, you think, oh, well, you just go into this part of the heart and just burn this little thing and everything's fine. It's like I just, fixed this electrical socket, and it's a really complicated procedure.
I'm so glad you mentioned that. That's important feedback for me, because actually that's how electrophysiologists consider AFib ablation to be one of the easiest procedures we do, because the femoral vein is a vessel in your groin. We put an IV in there. We thread the catheter through the IV, so there's no cutting, and it's a straight shot into the heart. That's our mindset because we deal with it every day, right? But we don't think about the other side of it. And I should really think about redoing that video, because if that video sent a message to you that this is a really complicated procedure, it's actually changed a lot over the decades. And so it's actually become quite a simple procedure. For example, we use something called a cryoballoon. It's a balloon. We go to these 4 different structures in the heart. We freeze each for basically 210 seconds and we're done. The actual ablation takes only 20 minutes. A lot of it's set up, a lot of it's technology and things like that. So,
okay.
I'm glad you mentioned that, because I have to really rethink what I'm putting out there now, because it can look a lot more complicated than it is, you know?
Yeah. You were talking about some of the risks as you go through one side of the heart to the other, and et cetera.
And I'm not discounting that. I mean,
right.
To your point, you don't want to just go to, whenever you're having a procedure done or any treatment, you want to go to someone who has high volume, done a lot, with a low complication rate. And that's the case with anything that you do on your body.
Absolutely. Including getting chiropractic adjustments.
Absolutely. Yeah, I mean, for sure.
So what are some of the most common medications that are used?
So oftentimes beta blockers include drugs such as metoprolol, atenolol. These are drugs, to what we were talking about earlier about the fight or flight sympathetic nervous system. Those are drugs that block the effect of that on the electrical system of the heart. So naturally, they lower the heart rate, they lower the blood pressure. And so they can be effective if someone especially has a rapid heart rate. There's a drug called propranolol, which often has an anti-anxiety effect as well, which can be helpful for premature beats. But the problem is that those drugs aren't easily titratable. And so, especially for young people, often don't like being on them because it really blunts your heart rate response to exercise. So people feel tremendous fatigue. It can exacerbate depression. It can exacerbate insomnia. From then, it can exacerbate ED. So, there's definitely trade-offs. But what's nice about beta blockers is they typically don't harm you compared to other drugs that we use. Calcium channel blockers, such as one called diltiazem, one called verapamil, these lower adrenaline in a different way. And what's nice about them compared to the beta blockers, not as much fatigue, but they can cause constipation and some ankle swelling. Those two classes of drugs have about a 40% efficacy rate for AFib long-term, so not the highest. And then you have the next tier of drugs called antiarrhythmic drugs, and there's about 5 or 6 that we choose from. And these drugs, if you think of the heart's electrical system as a bunch of doors opening and closing, those are what we call ion channels. And this is what these different electrolytes, like we're talking about, magnesium and sodium and potassium and calcium, these move in and out of the heart cells in the electrical system, and it generates current. Just like you think of any electrical thing, it generates a current. And so the drugs actually block these different doors, these doorways called ion channels. And so as a result, the drug can manipulate the current. Well, sometimes that works well in treating AFib and other issues, but sometimes it manipulates the current too well and it slows the heart rate down too much, or it creates a dangerous rhythm called ventricular tachycardia. And so the problem with drug development with AFib is that there's been no improvement in decades. And one of the reasons why is that we still don't have a good handle on the genetics, and we still don't have a good handle on how do you create a drug that's just specific for the top chambers of the heart, but do not affect the bottom chambers of the heart. Cancer, for example, oncology, wonderful drugs now, targeting the immune system. Same thing for many other conditions like rheumatoid arthritis, psoriasis. We don't have that quite yet for the electrical system. So those are the two. And so the antiarrhythmic drugs would include drugs such as amiodarone, sotalol, propafenone, flecainide, Multac, Ticasone. In case your listeners, if they've ever heard of those drugs, they have an efficacy of about 50% long-term with very high side effect profile. And again, my job here is not to push ablation. Obviously, I am biased. I do a lot of ablation. Of course, I'm biased and I believe in it. But I have been humbled in many cases where we ablate, AFib keeps coming back, and one day a spouse comes to the office and mentions the husband snores, and we have this aha moment, I should have done a sleep study, and then I do a sleep study and the AFib disappears. I mean, it's that much of a connection between sleep apnea and AFib.
Yeah, there's a huge connection between sleep apnea and a whole series of chronic conditions, and it's definitely underdiagnosed. And I think part of it just because people don't want to be put on a CPAP machine and they don't want to get diagnosed.
I'm glad you mentioned that. Not that I'm a sleep specialist, but what I refer a lot of patients for either home apnea link studies, which is where you can screen it at home, or a sleep study. And the top number one reason why people don't show up for the appointment or don't want to have it done is they don't want to get a CPAP machine. And my experience has been, in many cases, it's because they didn't have the right mask, they didn't have the right pressure setting, they didn't have the right education. They were just given a machine. It was ordered. They dropped it off one day. and they suffered with it, and then there was no follow-up. So I think it's important for people to know. And then there's a lot of other treatments. There's dental appliances, as you know. There's stimulators now. Medtronic makes one, for example, for treatment of sleep apnea for different, for like the tongue, for example, the glossopharyngeal nerve. So, but it is important to treat. And the number one way to treat it is to lose weight. That's such a big trigger.
Yeah, there's also a correlation between low vitamin D levels and sleep apnea.
Yeah. I didn't know that, actually. Is that true? I didn't know that.
Yeah, there's a few studies on it. I interviewed a dentist who was described how he saw a number of his patients turn around with getting the right amount of vitamin D.
Well, I'm going to have to keep that in mind because so many of our patients have sleep apnea.
Now, in his case, he felt it was important to get the vitamin D to the optimal level, not the normal level. So not just over 30, but say in that 50 to 70 range.
Okay. All right.
Nanograms per milliliter. And then I guess blood thinners are recommended sometimes too to prevent stroke, which is one of the side effects.
Yeah, I think it's important you touch on that. So stroke is the most catastrophic. And so the mechanism of a stroke is a blood clot forms in the heart through a substance called thrombin. And the antiplatelet drugs, such as aspirin, for example, don't work that well on thrombin. They work well on clots that form in the coronary arteries or in the brain, but in the heart with AFib, the atrium doesn't beat properly. You have this sort of lifeless bag of contractions, so the blood clot can form, stagnant blood. And so we traditionally have had blood thinners such as Coumadin or warfarin, which has a lot of challenges, efficacious, but a lot of challenges. And then there are a whole host of newer drugs that aren't so new anymore, Eliquis, Xarelto, for example, Pradaxa. And it's nice, these drugs actually have been studied in very large trials now, showing relatively low bleeding risk. It's all about the risk assessment. So you have the CHADS-VASc acronym I mentioned earlier. You add up the points to determine who's at high risk for stroke and AFib. And then you have what's called HAS-BLED, HASBLED. And that is another acronym. And that actually tells us who's at risk for bleeding on a blood thinner. And we can compare the two to then say, well, this 80-year-old person who has a high risk for stroke also has a high risk for falls because they fell 3 times in the last year. So that is someone we may refer for, there's a set of procedures called left atrial appendage occlusion procedures, a device called Watchman, for example, that you see a lot on commercials now from Boston Scientific. So these are devices that help isolate the part of the heart that is the source of the clot from traveling elsewhere. So the Watchman is like a little basket that gets implanted in the heart. And it's typically done, these are invasive procedures, but you're not cutting open the chest. You're doing it still through the femoral vein, for example. So there's definitely options for people. But one thing I would definitely say to people is, if you can't take a blood thinner because you've had a side effect or for whatever reason, get evaluated by a cardiologist or I think especially an electrophysiologist, because you may be a candidate for one of these other procedures and you don't want to have a stroke. Right. That's just the most catastrophic thing.
Yeah. One more question. This is just kind of a personal case from one of my patients. I had a longstanding patient, and he kept getting AFib from. He felt like it was coming from drinking something cold. Does that make any sense?
Yeah, it's that vagus nerve again. It's the parasympathetic nervous system. Yeah, I have a guy, a triathlete. Every time he drank Gatorade at the end of the race, he went into AFib. Like, how much of a reward is that? He just finished a race and he went into AFib because of the Gatorade. So yeah, you get esophageal stimulation. Really hot, really cold beverages can stimulate the vagus nerve. And then the esophagus is right next to the vagus nerve. So there's actually a direct sort of mechanical type stimulation. So yeah, there is actually reason for that.
Well, so, interesting. We talk about the vagus nerve all the time when we talk about gastrointestinal conditions. So
yeah. I kind of feel like the vagus nerve is getting a bad rap now. It really is. It really is important. It calms down.
Absolutely. It's the pathway for communication through the body between the brain and the gut, and the gut and the brain, and the gut and the heart, and the heart and the gut.
And it's so important. We mentioned earlier, and maybe this is a good parting note is, stress is pervasive, and there are so many great ways for creating, toolboxes to deal with stress, the classic stuff like exercise and being in nature and things like that. But mindfulness and breathing techniques and even simple things, a few minutes a day, it activates that parasympathetic nervous system that helps to counterbalance that fight or flight response. We were built to run away from dinosaurs. The problem is that we think that a conflict at work is a dinosaur, and sometimes it actually may be. The person may look like a dinosaur, but sometimes not. But our brain, our limbic system and our fight or flight response and everything interprets the threats that way. So it's important for us to always be mindful of how we are interacting with people. We can that way we can kind of show up as the best version of ourselves and not be so reactive, that we do have choices on how to act.
Yeah, big scary armchair dinosaurs. Doc.
Yeah, that was a great way of saying it without saying it. I love that.
What's the best way for listeners and viewers to get a hold of you and contact you?
Yeah. So the book is called Restart Your Heart: The Playbook for Thriving with AFib. It's on anywhere books are sold, including Amazon, Barnes and Noble. If you go to my website, which is draseemdesai.com, draseemdesai.com, I have a ton of information about the book and where to purchase, but also I have a blog, lots of complimentary advice there. We have a variety of different videos and things like that. And then I'm very active on social media. So especially on Instagram and Facebook, we even have AFib groups and things like that. So it's at Dr. Aseem Desai. That goes for Twitter, LinkedIn, Facebook, Instagram. And then I have a YouTube channel as well. It's at DRASEEMDSAI, and you can direct message me or reach out to me or follow me. I thrive on feedback. So that's the only way that any of us, your feedback about my video, I'm going to go look at that video now, because your feedback about my video is important, because I may be scaring a lot of other people and I need to change the way that video looks. So yeah, that's important feedback.
Okay, good, Doc. I enjoyed the conversation. And then when I put it up in about 5-6 weeks, I'll send you links and hopefully you can share it with your followers.
Yeah, I'd love to, and love to give you a roo. Thanks, Dr. Weitz, for this conversation today. I appreciate you having me.
Great. Thank you.